Assalamu alaikum wa rahmatullah. My name is Ahmed Hussein, clinical instructor in ICU. And this lecture will talk about SBAR communication. I am really sure that everyone of you know what SBAR is. And I will not go in the basics. So you know SBAR is for B for A for and recommendation. Now I want to ask anybody of you to tell me how he is using SBAR in his department. Who can tell us how you can use SBAR through your communication? What's the benefit of SBAR anyway? When we should use SBAR? When you are endorsing, you are handing over any information to other person and other healthcare worker. Okay. So who is using SBAR in their department? Who is using SBAR?
Our narrative nurses charting, it's in the form of SBAR.
Narrative, so documentation.
Yes, our documentation. Nursing.
You're documenting through
Yes.
SBAR, yes, okay. What else? SBAR is a method was invented by in aviation in the industry and used in military also. The main purpose of SBAR is not written, it is verbal communication. Because always verbal communication needs something to standardize it. Because we have different mentality, different mode and temper, and different volume of information to be exchanged at a fixed point of time. So sometimes you want to tell a big story, sometimes you tell one information. So you need to standardize the way we speak. Okay? Anyway, just make the communication in a standardized manner. So I will expect what to say, and the one who is listening expect what to hear. Okay? He know the standard or the format of the conversation. So you know what to say, and he know what to listen for. Okay? So this create redundancy. So he check on your conversation if you miss something, and you remind yourself if you miss something also. So if you make started by just mentioning the background, you will know that you missed the situation. If you jump to recommendation, you know that you didn't mention the assessment. The same also for the person who is receiving, he have an expectation for the conversation format. So you will know that you should start by situation, next one will be background, next one assessment, next one recommendation, and they are in a chronological order that they are based on each other. You cannot flip it. You cannot start by recommendation. First, you have to build up from situation, then confirm by background and assessment, then the recommendation based on this information. Okay? So during, what does it mean aviation industry? In the flight, there is a pilot and pilot assistant, and they are using SBAR to check on engine, to check on fuel, to check on pressure sensors, to check on elevation, check on closing of the passenger doors and everything. So they are checking these things through SBAR, etc. And if there is any change in pressure, okay, there is one engine failure like that, they will speak in SBAR. Why they are inventing this? Because there is high stake or high risk area. Very high risk, right? If you have any failure in the engines, in the doors, it will create catastrophe, the flight will fall down. Same thing with the military, they have very high risk area, so they use SBAR. So when you use SBAR, because very high risk communication stuff. So also when you are handing over the patient, you are transmitting very critical information or very important information to the next staff. When you're informing the physician with some certain information, change in lab, change in heart rate, change in blood pressure, the patient having an increased pain, this is very critical information. You want to transmit it in a clear way. So how to use SBAR? We have our objectives from this lecture is to, at the end of this lecture, you will be able to explain the SBAR, what SBAR stands for, we know already, benefits of SBAR, how to use SBAR and apply SBAR in clinical scenarios. So we know it is situation, background, assessment, and recommendation. So it's a structured method of communicating any information that require immediate attention and action. So why we need it? Because it is very simple method, easy to remember, prevent breakdown in communication, common language platform, and structure the conversation and clarify information need to be communicated quickly. Now, how to use SBAR? Now let's say, what does it mean a situation? In a situation is like how you start any story. How you start any story. Something to grasp attention. Something to grasp attention toward the main problem. Okay, so your main problem is the patient have increased pain. So you should start by this one. Okay, this is the situation. What is the current problem? So this is the situation. What can I mention in the situation? I should first identify which patient I'm talking about. I'm talking about patient in room 12 or room 10. I have to identify the patient through first IPSG, 4-digit name, and MRN. So you have identify yourself and your location and identify patient by 2 unique identifiers. So first thing, imagine that the person you are talking to is on the phone. First, you, as a phone calling etiquette, you just identify yourself. I am Ahmed from ICU, or I'm Ahmed taking care of patient in room 12. His name is so and so. This is, you identify yourself and your patient. Then you describe the main concern. Okay, I'm afraid this patient having tachycardia now. Right? So this is the main thing. That's the reason why you call or why you initiate the conversation. The next thing is describe the specific situation about which you are concerned. This tachycardia or new arrhythmia, etc. This is situation. Now see, example. This is Muhammad, charge nurse in ICU. I am calling because Mr. ABCD, 4-digit name, MRN, so and so, chest pain. He have chest pain, new initiated chest pain, difficulty breathing, shortness of breath. His saturation 84. You can say if you have one issue of this, you can just tell one issue. Or let's say in this scenario, the patient have these changes. So the patient suddenly have chest pain, difficulty breathing, shortness of breath, oxygen saturation 84 on room air, his respiratory rate is 34 per minute, his heart rate is 118, his blood pressure is 85 over 58 millimeter mercury. So you can see this alarming signs, and we have a clever nurse who detected these signs, and he want to inform the physician with these signs, right? So this is how he started his conversation. Identify himself and the patient, and then the main problem. Now background. What had brought him here? So we want to give a background about this patient. So, okay, suddenly someone, somewhere have these symptoms. Okay, I want to know what is the context of these problems. I want to know if this patient have chronic disease. I want to know if this patient was admitted from trauma. I want to know if this patient is post-operative. I want to know if this patient have a device. I want to know if this patient on ongoing medication. I want to know if this patient is non-hypertensive, etc. Right? You want to know that in the context of the main symptoms, right? Not just suddenly the patient is having chest pain. Yeah, okay. I want to know if he have any medication before to treat that chest pain. Maybe he is already on nitroglycerin, right? Maybe he is on antihypertensive medication, right? Maybe. So how before I guess, I have to know the background of this. So you know what brought this patient here and what happened to him. So we'll see. Okay, this patient maybe have incident at home and he came here for treatment. Suddenly have this new problem. Okay. So this is the main problem. What happened before the problem? Okay, this is the background. Okay. So I'm reporting the main problem. What happened before the problem? So let's say in this scenario what will be done. So for you say reason for admission, significant medical history like chronic disease, recent surgery, this patient just done operation for so and so. Overview of patient background include admitting diagnosis, date of admission, he was admitted since 1 week like that, prior procedure, current medication, allergies, laboratory results and other relevant diagnostic results. You need patient chart. So, okay, I will not speak better. If you have really good information about the patient, you can speak, but it's advisable that you take the patient chart with you when you speak with the physician. Okay, same thing also when you're giving handover to another nurse in the same department, or you are transferring the patient to other department, you will take the patient chart anyway, right? So you will take the chart with you to take the background. In this scenario, so the background was, he is 69 years old who is admitted to ER 2 days ago with a chest infection. And he is known case of COPD, DM, hypertension on regular treatment. This information is helpful or not? Yes. Now I have COPD, DM, hypertension. This can be a predisposing cause for MR. So I'm thinking, okay, I'm connecting the dots through the background and the current symptoms. And he is receiving IV antibiotics since 2 days. Until now, he is doing well. Otherwise, he is normally fit and well and independent. So this information is important or no? Important. So I'm thinking about antibiotics. So I'm thinking maybe the patient having chest infection before, he was suspected infection, so they started antibiotics. Or antibiotics since 2 days. Maybe if I have symptoms of infection now, maybe the antibiotics need to be changed. So I'm helping the physician to think about the main cause of the problem and relating, was the all solution working or not? Does he need to change the medication or not? Okay. And when I say he was well, doing well, otherwise normally fit and well and independent, means this is sudden changes. This means they give me the feeling that he was okay and suddenly he collapsed. Okay. Now, assessment. So what is the assessment? Now, your own observation and assessment for the patient. So you will mention the things that's related to the problem at hand. Now, this patient having chest pain, so you will say, okay, the patient having vital signs, so and so. You will say whatever respiratory findings you saw. Yes, I heard the chest, there is crepitations. The patient have, for example, distended jugular veins, etc. So whatever your assessment related to the problem at hand. So vital signs, clinical impression and concerns, abnormal findings. Maybe you saw lab results today changing. You have elevated troponin, elevated white blood cells, etc. This is highlight from the labs, can be mentioned in your assessment, plus your physical assessment. Maybe urine output, suddenly decrease urine output, suddenly increase urine output, suddenly increase potassium level or decrease, etc. Interventions you did. So for example, my assessment is that his vital sign has been stable from admission but deteriorated suddenly. So his vital signs now are abnormal, but it was normal before. And he is also complaining of chest pain, and there appears to be blood in his sputum. So I assess the patient. I have abnormal vital signs now. It is not known before. Suddenly it became abnormal. His sputum has blood sputum. He has not been receiving any venous thromboembolism prophylaxis. So I'm removing the thought that this because of heparin or enoxaparin or etc. So this is assessment. Okay, this format can be changed according to whatever assessment you do to the patient. You feel relevant to the information, right? Right. So in this case, if you do not have an assessment, you may say, I am not sure what's the problem, but I am worried. Okay. Now, if you have something new, you cannot do assessment for. For example, you have a drain, and the drain is leaking, or it's not functioning, or you have a chest drain, and the chest drain is not oscillating, or you have something new with the patient, or you have some device connected with the patient you cannot work with. There is nobody help you. Only the physician have to touch this device. So you say, okay, I'm not sure what's the problem with the device or the drain or whatever with the patient or with the wound. So you say that I'm not sure what's the problem, but I am worried. So you cannot assess this problem. You say you cannot assess, but you're still concerned about something changed in the patient. So what is the recommendation? The last thing is your recommendation, the end of the message. Now you build up information. From first you highlight the problem, the background, and whatever assessment surrounding information you were able to collect until now, and what do you want to happen. because you are the person who is beside the patient. So what do you think should happen? This is your input. This does not dictate that you have to give the treatment. No, recommendation doesn't mean you have to give the treatment. Oh, I think the treatment should be nitroglycerin dose to be increased or whatever. No, it doesn't need that. Whatever recommendation you think. Okay, I will give you why it means that. It can be meaning that you suggest a treatment, or you can say, I need you to come to see the patient. So this is another recommendation. First recommendation is you suggest a treatment. Okay, you have been with the patient since 12 hours, you have seen improvement with the increasing dose of nitroglycerin, maybe you suggest increasing nitroglycerin. This does not mean the physician will take your advice and immediately approve it. Maybe he will approve it, maybe he will not. But this means your own recommendation, your opinion about this problem. So what needs to be done further? Make suggestions, or I would like to get a stat X-ray for this patient, for example, in EBG. So they have sputum in the blood, the patient having chest pain, so let's say, and difficulty breathing. So the nurse is thinking, oh, maybe something with the lungs, something with the chest area is abnormal. So maybe chest X-ray will help, or maybe EBG. Maybe the patient is hypotensive now, let's start IV fluid. I would like, or you will say, I would like you to come immediately. Okay, this is your recommendation. So let's summarize. Again, this is Muhammad, a charge nurse in ICU. A reason I am calling is that Mr. ABCD in room 25 have chest pain, difficulty breathing, shortness of breath, oxygen saturation 84, etc. His heart rate is 118 and his blood pressure is 85/52. Now he is 69 years old. He's admitted from ER 2 days ago with chest infection. He is known to be COPD, DM, hypertensive, on regular treatment. He is receiving antibiotics since 2 days. Until now he is doing well. Otherwise he is normally fit and well and independent. His vital signs is stable from admission but deteriorated suddenly. He is also complaining of chest pain and there appears to be blood in his sputum. He has not been receiving any venous thromboembolism prophylaxis. And my recommendation is that maybe you will do X-ray and EBG, or I suggest you will come immediately. So if you heard this information, okay, without looking here, you understand the story, sir? It makes sense. It makes sense. And in the end, you can make the decision easily and quickly. Easily and quickly. Now you can, what actually happens? Now, for example, I will go to the doctor without SBAR. I will go to the doctor. Okay, the patient having tachycardia and chest pain. Then he will ask, which patient? Patient, he is in the room, name so and so. Okay, he will tell, okay, what medication he is on. I will go bring the file. I will look at his medication. He is on, for example, nitroglycerin. And say, how much rate? I will say, okay, 5 max. Then he will say, okay, how much his vital signs before. Then he will keep asking questions until he will clarify. This will take longer time. Okay, maybe sometimes he will not ask about important information. I will not tell it also. Then he will make wrong decision. Yani, for example, it's significant to tell intake or no output if you will give volume to the patient. Now I didn't tell him the patient is positive balance 1 liter since last 6 hours. Then he asks you to give 500 ml normal saline for the hypotension. Again, you add 500 ml to 1 liter, you have 1.5 liter positive for this patient and he have heart failure. You just carry order. So, he didn't think about intake and output. So, now one physician told me story that in Canada right now, or in the West anyway, nurses are taking care of everything. One physician can handle all the hospital in consultations. So the nurses are just calling, telling this is my assessment, this is the ongoing treatment, and the physician just give advice to change treatment, to implement treatment, etc. And all documented. So can we do that? Yes, we can do that, but we must communicate in this method. We must communicate in this method. So if you want to elevate your level of communication and level of proficiency, you should use always the standard methods and the best way of communication. Yes? So this is the best way. Now, if we think about this is nurse to physician example, let's say nurse to nurse, which is also very important, and it happens every shift, sometimes twice per shift when you transfer a patient. So before the shift ends and receive another patient, so you have more frequent nurse to nurse handover. So what you should give in the situation? So in the situation, again, you will identify the patient and mention the reason the patient is admitted and still in the hospital. Now let's say your patient is in, let's say, what's your department?
SSU.
SSU. Let's say the patient was still in SSU for a reason of his waiting for surgery or he just recovering from surgery. Let's say I'm just assuming that whatever cases you have there. Now, you are mentioning this in the situation. So my patient, name so and so, age so, ID so and so, in room so and so. He is here, he is stable, and he is here for surgery, or he is here for recovery from surgery, or he is here for waiting for drain output to decrease, or under monitoring. So this is the reason the patient is in your department. The patient should stay in the hospital if he is okay. No. If he does not need the hospital, he should be at home. Why he still needed the hospital? This is the question you will answer in the situation. So this is the things that to put in front of your colleague when he receives the patient. This is the main concern why the patient is in the hospital. صح ولا لا? Because we are serving this cause. Why the patient is in the hospital? Because he is sick. Sick, for example, in his heart, or sick in his lung, or he have wound to be healed. So the nurse, you and me, we have to fix this cause. Huh? Work until the wound is healed, until the patient will be able to walk again, the patient will be independent again. So this is the reason as a nurse, as a team working for. So this is the first thing to be mentioned. Why the patient is still in the hospital or unit. Or for example, when you are transferring the patient, why the patient need to be transferred to the other department. So for example, CCU, transferring to ward, you are saying that the patient recovered from CAR and he is for monitoring in cardiac ward. صح ولا لا? That's why he is transferred, right or wrong? That's why this is the situation. Then, including of course identification of the patient. Then what is the background? In the background you say the history of the patient. Also this patient was admitted 1 week before and he had this procedure, have that procedure, and he was intubated, then extubated, then he is stable now. Then recent events they did for him so and so. Summary of what happened to the patient in the last period and chronic disease. So he is non-hypertensive, non-diabetic, etc. Okay? Just rearrange the same information you are giving through this order. First thing, you